So once you've seen them for their initial appointment, you should by now have a pretty good idea what is going on. Now that's not always going to be the case. So occasionally you're going to have to refer someone off for a scan because they might have some symptoms that you really want to that you're concerned about. So they might have some pain that you're palpating along a bone, and their subjective history may allude to the fact that there may be a bit of a stress injury involved or something a little bit more serious that you just want clarification. So with a scan, it's really, really important that you refer off to either confirm or to negate your working diagnosis. It's not advised to send someone off for a scan on a bit of a fishing expedition where you're saying, look, there's just some general pain here. Find something in the scan for me, please. The clinical assessment really is going to provide up to 80% of your diagnosis. A scan may come back inconclusive, but your clinical reasoning and clinical testing is generally going to give you a really much more reliable idea of what the issue is. And we know that with issues such as Achilles tendinopathy, that the scan really isn't indicative of the pain profile of the patient. Sometimes we can see really awful looking Achilles with no symptoms and a pretty decent looking Achilles with some minor issues that is causing the patient significant discomfort. So be a little bit careful about using scans, but clearly when they're needed, go for it. And it's probably not going to be appropriate then to construct a treatment plan until you're confident of what your likely diagnosis is for this patient. So assuming that you have got a likely diagnosis and they do not need scans at this point, that first follow-up is where you again start to build and continue building that rapport with the patient. So hopefully you're going to first of all ask them, how's the condition going? What have they experienced following the session with you? So if you've done some manual therapy, you've done some taping, you've done some padding, how did they respond to it? They might have not responded very well at all. And sometimes explaining that to them, look, that's okay. This is just about trying to work out exactly what your diagnosis is, or no, we don't necessarily expect a huge change in this short period of time. Sometimes the patient may have had a very adverse reaction, whether it be to the exercises, to the taping, or to the padding. If we then don't see them for a week or two after that initial consult, there's a really big risk that things are likely to escalate. So if someone were to come and have taped and their foot goes from 4 out of 10 to an 8 out of 10, and they've been in a lot of pain, having trouble sleeping, and they're not booked in to see us for a couple of weeks, we risk them going to the general practitioner, sending them off for a scan, or maybe having to end up going down the path of a cortisone. When we're saying, look, response is, it's unusual, but we need to do this, this, and this to get you back on track. So it's really, really important that we do have that follow-up to not only obviously start treatment as soon as possible and get that person out of pain as soon as possible, but also on the flip side, that if something they did have an adverse reaction to anything that we've suggested, that we're there to help provide that reassurance and that guidance and education to get things back on track and say, okay, let's not do that. Or maybe the diagnosis that we had in the initial is not actually the case. We need to do some more further investigation. So that's why that second follow-up within 5 days maximum is super, super important. If we're aiming to push that person out to a week or two, we risk obviously them having issues that we really don't have an opportunity to help them with. I think it's really important that we're aware of some of the biases that we bring to our consultations. The big one is a knowledge bias. As practitioners, we have a huge amount of knowledge at our disposal through our experience and through our study. The patient really has limited to no understanding of how the foot functions and the severity of their issues. So you might have an issue that that's perhaps not on the severe end, but the patient doesn't know that. So to be sort of slightly, or to appear dismissive and say, look, I'll see you in a week or two for this issue, can actually create what we discussed previously about that perceived indifference, where the patient thinks, well, kind of being fobbed off a bit here. I'm in actually quite a lot of pain. It's really affecting my daily life. The practitioner doesn't even want to see me for 2 weeks. So really making sure that, yes, okay, we might know that that's not an overly serious issue, but the patient doesn't, and providing that reassurance in that first few stages where we can start to actually get some wins and start to get the pain and function improving can be really, really important. So in that follow-up consult, we'd obviously discuss, as I said, how the treatment from the initial consult has gone. And then you spend perhaps a little bit more time in the first part of that consult, going through some objective testing. So perhaps a little bit more broader, starting to work out what might be some of the possible causes for this issue, whether it be some calf function issues, some joint range of motion problems, is there some limb length issues or some imbalances, or some strength deficits, all of those sorts of things. You can start to widen the net in terms of what some of the things might be functioning. And you obviously can start looking a little bit more proximal too. This is where you probably are starting to understand a little bit more about what might have triggered this in the first place. Next, more than likely, I'd say in the vast majority of cases, you're going to have prescribed some exercises. So typically after that initial consult, you might have just sent out via PhysiTrack some basic exercises for the person to start on. This is in that first follow-up appointment where you would actually physically go through these exercises with them. So you might take them into the gym and actually demonstrate these exercises with them. Make sure they're doing them properly, discuss the importance of the exercises. If you just send them off in an email, the person generally thinks, like, in terms of the weight of those exercises, low down on the list. We know for a lot of conditions, say tendon injuries, that they're high up on the list. So if you don't really prioritize it in the actual consult itself, you're typically going to find that the person themselves doesn't really prioritize them. So actually going through with them, maybe even just doing one set with them, or even the whole lot, so you can work out if there's any issues there, they're getting any pain, they need some, I guess, some help and coaching around how to do the exercises, they can do it in that consult. So when you do let them go by themselves, you're confident that they're actually going to be doing them properly. Then that remainder, and I'd say sort of at that 10 to 15 minute mark, you're going to probably spend the majority of that appointment on the manual therapies. So whether that be your taping, your shockwave, you're adding padding to shoes, your dry needling, your soft tissue work, all of those things to try and help get the pain down. We know this point in time, we're not going to likely see much physiological change in the area that we're treating. That's not the objective. The objective initially is to start to get the pain to improve, to potentially improve a little bit of function. But really it's about building that confidence and an ability for the patient to start reloading that. And manual therapies we know are very, very effective, say 2, 3, 4 days to help get the pain going. If we can do those therapies and start to get them moving a little bit better and a little bit less pain, we can start to change that behavior, start to change that, that aversion or that fear to movement, which we know, that kinesiophobia, which we know can be really problematic and limiting on someone's progress. So doing those things in those early phases can be really useful to actually getting that person back and moving properly sooner. So that's the main priority in that second follow-up. In the next video, I'll go through what we're likely to be doing in the third session, so the second follow-up after the initial appointment.